Welcome to the student project presentation of SGD B5. Today, we will be presenting about pneumoconiosis. These are our group member.
Okay, now we go to the chapter 1, that is background. Next. Okay, so hello everyone, my name is Fairoza Husnia Adiba with relationship of student number 102. So I'm going to explain about the background of this student project. So pneumoconiosis is a group of lung disease due to airborne inhalations, commonly from mineral dust or fibers that spreads in the workplace environment. They cause inflammations in the lung. The type of pneumoconiosis are dyspnea, diminished exercise capacity, slowly progressing dry cough, and it could be asymptomatic. Based on the global burden of disease, they reveals that although there has been a decline in the prevalence of pneumoconiosis since 2015, a considerable number of patients remain active. The delay in the diagnostic process may result in complications. Silicosis may develop into carcinoma or tuberculosis, while asbestosis can lead to pulmonary fibrosis or malignancy. So these conditions can affect patient quality of life, especially those with high risk occupations of pneumoconiosis. So it is important to understand the pathological aspect of pneumoconiosis to obtain valuable tool for preventions, early detections, and effective therapy. I guess that's all from me. Thank you. Next.
Hello, my name is Kenisha Tedijanto and the last three digits of my student number is 154. And in the student project, we will be discussing about the definition of pneumoconiosis, its epidemiology, its pathophysiology, the differences between its types, its clinical manifestations, the diagnosis of pneumoconiosis, its prevention, and also the treatment of pneumoconiosis. The benefits of discussing these will be implementing the author's knowledge regarding pneumoconiosis to add information and improve our related understanding, and presents basic data for further research on pneumoconiosis. And the rest will be discussed by my teammates. Thank you.
Hi everyone, my name is Ngurah Bagus Bhismaka Ariel Vivekananda Putra, and my last three digit of student number are 124, and now we will move on to chapter 2, literature review. So now I will start this chapter by discussing about the definition and epidemiology of pneumoconiosis. Pneumoconiosis refers to a group of occupational lung disease caused by the inhalation and retention of organic or inorganic dust, fumes, or fibers commonly found in industrial setting. The most prevalent types include coal workers pneumoconiosis, silicosis, asbestosis, although other substances like tin, barium, and zirconium can also lead to these conditions. Prolonged exposure to this particle causes inflammation and fibrosis in the lungs, resulting in permanent damage. Pneumoconiosis typically develop after years of exposure and may continue to progress even after the exposure ends. The severity of the disease depends on factors such as the size, toxicity, and the lung's ability to clear the inhaled particles. In general, particles with a median diameter of 0.5 to 10 micrometers are small enough to reach the alveoli and cause harm. Pneumoconiosis is one of the most common occupational diseases worldwide, with a particularly high prevalence in developing countries. From 1990 to 2017, the number of cases rose by 81.1%, with a significantly higher incidence among males and older individuals. The Global Burden of Disease study in 2010 estimated that pneumoconiosis accounted for 125,000 deaths globally. The prevalence of pneumoconiosis varies significantly by region. In Australia, data from 1979 to 2002 recorded over 1,000 cases, with 56% attributed to asbestosis, 38% to silicosis, and 6% to CWP. In both the US and the UK, the prevalence of CWP ranged between 2.5% to 30% depending on the coal content in mining areas. In the US, the prevalence of pneumoconiosis was around 30% in the 1960s, but it dramatically decreased to approximately 2.5% by 2002, due largely to improved workplace controls. In the UK, data from the SWORD project 1990 to 1998 reported a pneumoconiosis prevalence of around 10%. Similarly, in Canada, pneumoconiosis cases accounted for 10% of occupational lung disease reports from 1992 to 1993. However, in countries like South Africa, the prevalence is much higher, with data from 1996 to 1999, showing 61% of workers with pneumoconiosis. China also present with a high burden, with 569,129 cumulative cases reported between 1949 to 2001. In Indonesia, specific studies on pneumoconiosis prevalence are limited and primarily based on small-scale investigations within individual companies, with prevalence rate ranging from 0.5 to 37% depending on the sector. Table 2.1 summarized the prevalence of pneumoconiosis in Indonesia from several studies.
Okay, hello everyone. Before I continue my presentations, let me introduce myself. My name is Gede Prabha Putra, and last digit of student ID number is 022. So today I will give a brief overview of the pathophysiology of pneumoconiosis. So pneumoconiosis begin when the fine dust particles are inhaled and bypass the respiratory defenses, reaching the alveoli. This triggers an inflammatory response where alveolar macrophages attempt to engulf the particles and releasing the pro-inflammatory cytokines like tumor necrosis factor alpha, interleukin 1, and interleukin 6. Over time, as chronic inflammation progresses, it will activate the fibroblasts, leading to excessive collagen buildup, fibrosis, and scarring in the lung. As fibrosis progresses, lung function is impaired, making it difficult to breathe and causing symptoms such as chronic cough, shortness of breath, and fatigue. In advanced stages, complications like pulmonary hypertension and respiratory failure may develop. Unfortunately, the fibrosis is irreversible with limited treatment options available. Recent molecular research, including GWAS and lipidomic studies, has identified genetic markers and lipid metabolism changes that may help in developing new diagnostic and therapeutic approaches. Okay, so that's all the presentations from me, and thank you.
Hello everyone, please allow me to introduce myself. My name is Evrilla Deidree and the three last digit of my NIM number is 163, and today I'll be telling you about silicosis and asbestosis. First of all, silicosis is a fibrosing interstitial lung condition caused by inhaling substantial amounts of respirable crystalline silica. Non-fibrotic lung illnesses linked to RCS exposure includes emphysema and related chronic obstructive pulmonary disease, lung infection, and lung cancer. Silica exposure has also been linked to autoimmune rheumatic illnesses and inflammatory renal disease. On the other hand, asbestosis inhalation causes a localized inflammatory response that strives to remove the inhaled asbestos fibers. Asbestosis is a fibrotic parenchymal illness resulting from asbestos exposure. After several decades of initial asbestos exposure, individuals develop dyspnea, exercise intolerance, and hypoxia, as well as restrictive physiology on pulmonary function testing similar to other interstitial lung diseases. Pleural plaques are the most common pleural manifestations, and they are localized patches of pleural fibrosis that are frequently discovered by chance. That is all from me. Thank you for your attention.
Greetings, I'm Dewa Prabha with the last three digit of student registration number is 101, and I'm going to talk about types of pneumoconiosis. Firstly, I'm going to talk about coworker pneumoconiosis, which is caused by coal dust inhalation. There are two types, firstly simple and also complex. And occupation at risk for this coal miner or coal worker pneumoconiosis are coal mining, coal trimming, graphite mining, producing carbon electrolytes, and also carbon black, which risk factor are exposure to coal dust, especially anthracite, bituminous, subbituminous, and also lignite. Secondly, I'm going to talk about bariolysis. Bariolysis or chronic beryllium disease is caused by exposure to beryllium, which as at risk occupation are alloy production, ceramics, radiography equipment manufacturing, beryllium extraction, and also smelting. Beryllium stays in the lung and causing a slow disease onset and progression even without continued exposure. It is also classified as class 1 human carcinogen, making it even more harmful for human to work with. I think that's all that I can say. Thank you.
My name is Putu, Anindita, Wira, Cahyani, and my last three digit of ID number is 185, and I'll be presenting about siderosis and barytosis. So, siderosis is a benign pneumoconiosis caused by exposure to metallic iron or iron oxide. It's associated with occupations such as mining, steel production, and jewelry manufacturing. Iron has minimal fibrogenic properties, so most exposed individuals are asymptomatic. Chest X-rays may show interstitial fibrosis due to iron pigment deposits, which give the lung tissue a reddish-brown color. Histologic features include iron pigment deposits around blood vessels and bronchioles, appearing dark brown to black with a golden brown halo, differentiating this from hemosiderin. And the next one is barytosis, which is a rare form of benign pneumoconiosis resulting from the aspiration of barium sulfate particles. This condition is typically asymptomatic and does not impair lung function. Barium is toxic at high concentrations. Barium carbonate, a highly toxic soluble barium salt, is the most frequently encountered compound.
My name is Gede Darmawan with last three digits student registration number of 100. Clinical manifestation. Co-workers pneumoconiosis or CWP. Simple form is asymptomatic with small lung nodules. Complicated case cause breathlessness, fibrosis, cough, and right heart failure. Silicosis. Often asymptomatic early, but advanced form lead to significant respiratory disability or fatal acute silicosis. Asbestosis, progressive shortness of breath, cough, crackles, and finger clubbing, resembling idiopathic pulmonary fibrosis. Beryoliosis, nonspecific symptom like cough, fatigue, or weight loss, progressing to restrictive lung disease with granulomas. Siderosis, generally asymptomatic, with rare cases of interstitial fibrosis after long-term iron dust exposure. Barytosis, typically asymptomatic, with no lung impairment unless large volume barium inhalation occurs.
Hello everyone, my name is Aprilia Sisyanti with the last digits of student number 229. Today I will explain about the diagnosis of pneumoconiosis. Pneumoconiosis is diagnosed by a combination of manifestations of lung symptoms, physical examination, lung nodule and mass detection on a chest X-ray or CT scan, and occasionally a biopsy. Exposure to substances known to raise the risk of disease can significantly increase the diagnosis of pneumoconiosis. There are three primary criteria for diagnosis of pneumoconiosis. The first one is sufficient latency time and exposure to mineral dust, which is known to cause pneumoconiosis, such as silica, coal, and asbestos exposures. Second is the identification of a distinctive chest radiograph that satisfies published guidelines for pneumoconiosis diagnosis. The third is the absence of a disease that might mimic pneumoconiosis. For the step to diagnosis pneumoconiosis, you can read the flowchart below. That's all about the diagnosis. Thank you.
Hello everyone, my name is Nilokade Asri Bintari with the last three digits of my student number R063. Today I would like to present about the prevention of pneumoconiosis. Prevention of pneumoconiosis relies heavily on workplace exposure management and health management regulations. One example of a regulation related to the prevention of pneumoconiosis in Japan contains protective equipment. Therefore, one method of preventing pneumoconiosis can be done with personal protective equipment. In addition, adequate nutrition and health checkups are recommended to prevent pneumoconiosis. Okay, that's all from me. Thank you.
Hello, my name is Dewi with the last digits of my student number R146, and I'm going to explain about pneumoconiosis treatment. While pneumoconiosis is currently untreatable, a holistic approach involving symptomatic treatment, complication management, and rehabilitative care can slow disease progressions, reduce symptoms, and improve overall health and quality of life of the patient. For advanced cases, lung transplantation is the only definitive treatment. Management also includes addressing symptoms like coughing and breathing difficulties, managing complications such as infections and COPD, and incorporating interventions like whole lung lavage. Recent research has identified several promising medications, including immunosuppressive drugs, corticosteroids, antioxidants, and vasodilators, which show potential in reducing pulmonary inflammation and fibrosis. Pulmonary rehabilitation is a critical component of the treatment, offering personalized interventions such as physical and strength training, respiratory muscle training, psychological support, nutrition, and specialized therapies like rehabilitation surgery to improve physical and respiratory function of the patient. That's all about treatment of the pneumoconiosis. Thank you.
Hello everyone, my name is Cendrawan Han Santoso with the last three digits student number 170. I would like to discuss about the conclusion. Pneumoconiosis refers to a group of occupational lung disease caused by the inhalation and retention of organic and inorganic dust or fumes, commonly found in industrial settings and is one of the most common occupational diseases worldwide, with a particularly high prevalence in developing countries. There are several types of pneumoconiosis, which are silicosis, asbestosis, co-workers pneumoconiosis, berylliosis, siderosis, and barytosis, which are respectively caused by exposure to silica, asbestos, coal, beryllium, metallic iron or iron oxide, and barium. Progression of disease is caused by inflammation from constant exposure of particles, which eventually leads to progressive fibrosis and scarring of the lung tissue. Symptoms of pneumoconiosis ranging from asymptomatic to dyspnea, exercise intolerance, and hypoxia, as well as restrictive physiology on similar restrictive lung diseases. Diagnosis can be done from thorough anamnesis to determine possible causes and to exclude other possible diseases. Prevention is done through the usage of personal protective equipment and constant health checks to see possible warning signs. Definitive treatment for pneumoconiosis is lung transplant. Other treatments are for symptomatic, complication management, and rehabilitative care to improve health outcome and quality of life. Thank you.
Thank you for your time and attention. We hope our presentation on pneumoconiosis has been informative and insightful.